Hey everyone, welcome to this presentation on ultrasound-guided vascular access in the neonatal population. My name is Katie Schaefer. I'm the clinical education resource nurse for the neonatal transport team here at Children's Memorial Hermann in the Med Center. I am also one of the original creators of our POCUS program for vascular access in the NICU. This presentation is a really general overview of all of the basic functions of ultrasound, setup, assessment, troubleshooting, guidelines, things like that to help you get started. And I hope that you enjoy the presentation. To begin with just a brief overview, ultrasound guided practice has been around in the NICU for about the last 20 years. Here at TMC, we set out to build our program about 3 years ago. Initially, when we started, we did not have access to our own equipment, and we did not have anyone on the unit who was actually ultrasound trained. So we had to work with some of our friends from the pediatric transport side and the life flight side, who both brought different experiences and different techniques and different specialties to the way in which they taught ultrasound. But by using their teaching as a baseline, we have been able to very slowly build an extremely successful program here in the NICU at TMC. We currently now have 2 ultrasounds that are dedicated just for use by the neonatal transport team, and they have been absolutely instrumental in changing the way we perform vascular access in this NICU. And so we're going to go over through the rest of this presentation just some of the basics of how we got this started and how we use the ultrasound in this unit. Looking at the educational objectives of this presentation, I hope that by the end you can look at and identify the clinical indications and benefits of using ultrasound-guided peripheral insertion for vascular access. We're going to go over the basic procedural steps in terms of using POCUS. We're going to talk about the evaluation process and look at our anatomy for what types of vessels and how we position patients and things like that in order to be successful. And then we're going to walk through the correct technique for obtaining peripheral venous access under ultrasound guidance. So indications for use. So in our NICU currently, as a transport team, we typically utilize ultrasound guidance as a first line in obtaining any type of vascular access in our patient population. So whether that be arterial or venous lab draws, peripheral IV access, peripheral arterial line access, so like a peripheral art line, or PICC line, a peripherally placed central catheter. All of those types of access, we have found that we can be extremely successful in all types of different patients. So everyone from the 450-gram micropreemie all the way up into our kids who are really on the pediatric spectrum, the kids that are with us for over a year. And we've really found that this tool has helped us to make better decisions about what type of access our patients need to be more efficient and effective as a team, meaning we're spending less time at bedsides. We are making less attempts in order to be successful. And ultimately, that's all leading to a much better patient experience, much better outcomes for our patients. Our providers are able to dictate what type of care they want much more effectively because we are not as limited by access or types of access that we're able to obtain, which was a huge problem for us in the past. And we can really make the best help with the medical team, help make the best decision possible for what we need to do for this patient to get them the treatment that they need. So in our NICU, we utilize the GE VenueFit ultrasound, and the probe that we use for vascular access is a linear 10 to 22 megahertz probe. So this is currently the smallest probe on the market. It is also the probe with the highest resolution meaning that it doesn't do a very good job of showing you vessels below about 2 centimeters, but it does a really good job of showing you vessels that are, from the surface of the skin down to about 1 or 1.5 centimeters of depth. And this can be arterial or venous vessels that we're looking at. And what we have really found is that for the neonatal population, this probe size and really high resolution at those more shallow depths, it has really served our particular population incredibly well. And that we haven't really seen, even in our larger patients, we haven't really seen a need to scale up to a larger or deeper probe. We've found that we're able to be successful even in more of those pediatric type patients with this smaller probe. But likewise, we are still able to identify vessels in our very smallest end of patients. So this linear probe really fits the bill for the types of patients that we take care of in the NICU. You can kind of see here in this photo that I have put into the screen, this is a basic setup for starting a peripheral IV in an upper extremity on a baby. You can see that the probe itself is being held in a perpendicular way to the arm. These probes, the type of probe that we use for vascular access is a linear probe, meaning what it's going to give you on the screen is essentially a very, very thin cross section. Think of like a credit card slice directly down through the extremity that you are scanning. And so this high frequency linear image is going to be displayed on the screen. And what that's going to allow you to do is it's going to allow you to identify all different types of vessels, both your arteries, your veins. You can see echoing around where there's more solid structures like bones. You can also see nerve bundle fibers. So for our purposes of attempting to put peripheral IVs or peripheral art lines or lab draws, things like that. This type of probe is really, really the gold standard in terms of vascular access. You can see that the way the probe is being held, um, ultrasound is a non-dominant hand procedure, meaning that whichever hand is dominant, which for most of us is going to be our right hand, whichever hand is your dominant hand, that is the hand you're going to hold your needle, whether it be an angiocath or whatever type of needle you're using, that is going to be held in your right hand. And then the probe itself will be held in your left hand, which is typically our non-dominant hand. So, sort of similar to intubating, you're going to get your view and guide yourself in with your left hand, and then your dominant hand, your right hand that's holding the needle, is going to sort of follow the path that is laid for you by your probe hand and looking at the images that you're seeing on the screen. So you can see how in this picture, Kristen is holding the probe in sort of a C grip. She has it between her thumb and her index finger, and then she's sort of using her other fingers to kind of stabilize the back end of the probe. And you see how she has it pretty much in a perfect 90-degree angle to the extremity that she is scanning. And that's really, really ideal. Sometimes it can be pretty easy to let that probe sort of fall one way or another. And the whole idea, the whole name of the game here is to identify your needle tip, the very tip of the needle, and guide it directly into the vessel. And so if you start to angle the probe sort of one way or the other, what that does is instead of giving you a really clear image of the very tip of the needle, it can give you some casting or some shadowing on the screen. And essentially what you're seeing there is the ultrasound waves are bouncing off of the shaft of the needle. And instead of just seeing a nice bright white dot representing the tip of the needle, you can kind of get some echoing down the screen. And while you may actually be on the needle, you are not really truly seeing the tip of the needle. And unfortunately, what happens there is that you may think that you are guiding the needle in to be in the center of the vessel. But unless you're able to identify the very tip of the needle, what happens is that while the center of the needle may be in the vessel, the tip of the needle may actually go through the posterior wall or kind of extravasate itself outside of the vessel wall while you think you're sort of guiding the middle of the needle into the vessel itself. The other big important thing in terms of orientation of the probe itself is that in all ultrasound probes, whether it be a GE or some other kind of model, there is always some sort of dot or notch on one end of the probe itself. That notch or that dot always needs to be orientated to the left of the patient. So it always needs to face left. Doing that will give you a direct correlation when you're moving the probe on the patient's arm. That means if the vessel starts to move to the right and you move the probe to the right, that's going to keep everything nice and in line. If you pick up the probe and it's backwards, if that notch is aligned to the right, when you try to move to the right, the screen is actually going to move to the left. And you can pretty quickly identify that where you're trying to go is not where your probe is moving to. So happens to everyone, but just one of those things to keep in mind when you're very first starting and you're learning to scan and working on probe placement and identifying vessels and things like that. Making sure that that notch is always orientated to the left when you're holding it, and then that's going to help you out when in terms of your scanning. You can also see some gray lines on the probe itself. So that gray line runs right down where her thumb is, runs right down the center of the probe. That actually corresponds to a yellow triangle on the ultrasound screen itself. And so it's really important when we have identified the vessel that we're going to use to put our catheter into. We want to orient ourselves so that that vessel is directly under the gray line, therefore directly lined up in the center of the probe. That does a couple of really good things for us. Number one, it gives us the widest margins, so it gives us a good amount of tissue to either side of the vessel, so that if we're not, dead on the first time we introduce that needle into the skin, we've got a good view right around that vessel to be able to pick up that needle tip and kind of make those adjustments as we need to and guide the needle into the vessel itself. The other part is that when you're lined up, when you're making that initial needle poke, that is going to be the one moment where I want you to take your eyes off of the ultrasound screen and look down at your hands. And so if you've got everything lined up, what you're going to do is introduce that needle um, directly under the skin, right, aimed right at that gray line. That hopefully is going to put you in a spot where that needle, if it's not in the vessel, it's really close to the vessel. And what that's going to do is make it a lot easier for you to make adjustments and walk your needle and your catheter all the way into the vessel. There are some other settings on the ultrasound that we can go over once you actually start practicing. The two main things that we use are called depth and gain. Depth is pretty self-explanatory. Obviously, I can adjust how deep the probe is going to scan into the extremity. Typically, for probably about 90% of patients, we use a depth of 0.8 centimeters, so almost a whole centimeter down. That's usually plenty deep enough to show us, particularly if we're working in the periphery, that's going to show us plenty of vessels. We're going to actually see pretty much all the way through the arm or the leg at 1 centimeter for most of our smaller patients. And some of our very, very tiny patients, our micro preemies, less than 25-week kids, I may lessen that depth a little bit to 0.5 just to make those vessels, because they are so small, make them look a little bit bigger on the screen for you. In our larger patients, we can go down to a depth of 1 centimeter or possibly even 1.5. I think in 3 years of doing this, I've needed to go to a depth of 1.5 on probably less than 10 kids total. So it's not very often that I have to drop the depth down that low. And typically those patients were for lower, that depth was used for lower extremity PICC lines, so vessels in the leg that were pretty deep. But otherwise, most of the time, depth of 0.8 is going to be kind of your starting point or kind of your ground zero for most of the kids that you're going to be assessing. Gain is a term that reflects the brightness or the darkness in terms of in terms of like the screen that you're looking at. And so, really, what you're looking to do is to create contrast between the inside of the vessel, which should hopefully appear quite black, because if it's well perfused and has good blood flow, that shows up as being very dark on ultrasound. And then the soft tissue that around it is going to be more echogenic, it's going to appear more white. And so, what we're usually doing with the gain is kind of adjusting the brightness and darkness to try to create as much contrast as we can between the interior part of the vessel and the soft tissue around. What that's going to do is it's going to bring that wall into really nice focus for you, and that's hugely helpful because it really helps you differentiate between, am I in the wall of the vessel or am I in the center of the vessel? And what we're trying to do is to keep our needle tip in the center of that vessel the entire time, so we're able to put as much of the catheter into the vessel as possible. And then in terms of placement, we utilize what is called an out of plane technique, meaning that you are never really going to see more than the very tip of your needle at any time. You're going to introduce, once you get set up and get the probe where you want it, where you want to enter the vessel, you're going to, like I said, look down at your needle tip. You're going to introduce that needle tip under the skin. Then your eyes are going to go back up to the monitor, the ultrasound monitor itself, and we are going to pick up your needle tip, make whatever adjustment we need to if we're not perfectly in the vessel, and then slowly, slowly advance the catheter into the vessel. And the system that we use to do that is an out of plane technique where we will actually visualize the needle in the vessel, and then we will slowly advance our probe away from the needle towards the patient. So walking away from where you are, losing sight of that needle tip for just a second, getting a new picture of where the vessel is at, and then very gently advancing the needle to follow that same plane that you were on once you're in the vessel. And then once you see that needle tip coming into your screen again, you're going to hold nice steady pressure on the needle and you're going to walk your probe hand away from the needle tip, proximal to the, and go proximal to the baby, closer to the baby, and gently then advance your needle tip again to follow where that probe is. So the prompts or the phrasing that we use here is probe away, advance your needle, probe away, advance your needle. And then if we get a little bit too far away from our needle tip, or if we're having trouble, we'll pause where we're at with our needle and we will say probe back. And so we will move our probe then back to our needle tip to pick up exactly where we are. But it is very much a two-handed process that requires really good coordination of both your left and your right hand. And we don't ever want to try to move those hands at the same time. Our probe hand or left hand or non-dominant hand really guides the movements of our right hand. And so those two hands have to talk to each other in a very coordinated way of probing away and then advancing a needle and probing away and advancing a needle. And the way we teach it here is that we really encourage you from the very beginning to learn to walk the catheter all the way into the vessel. Number one, that really provides you good opportunity to practice those fine motor skills and to develop them. Number two, when you go to start doing more difficult lines, PICC lines, bigger, deeper vessels, that technique, you will need to be able to walk that introducer entirely into the vessel because those vessel walls are so much thicker and so much deeper that you're not going to be able to get into them in just one or two little, ooches on the vessel wall. It's not going to let you in very easily. So building this technique with peripheral vessels is really going to pay off down the road when we get to PICC lines. And then finally, the more catheter that you can place in the vessel within the vessel wall, typically the longer your peripheral IVs or your arterial lines are going to last. So it's going to benefit you because you're not going to have to come back and repeat your work, and it's going to benefit the patient because they're going to have a much more longer functioning line. I know that last slide was a lot of information about kind of the basic steps of placing um, ultrasound guided peripheral IVs. And now I'd really like to talk a little bit about how do we tell the difference between an artery and a vein? Because anytime we go to do an assessment on a patient, when we're thinking about using the ultrasound to place an IV, the biggest thing that we need to do is make sure that we are identifying our vessels correctly, that we are placing IVs into healthy vessels that are ready to be accessed. That's going to make sure that we are doing the best thing for our patient and not risking any of their distal perfusion or anything like that by entering a vessel that we did not mean to enter or causing any damage to a vessel that we did not mean to enter. So in babies, arteries and veins initially under ultrasound appear really, really similar. We've worked with in the past, we've tried Doppler color flow and things like that. I'll tell you, because of babies' natural extreme collateral circulation, particularly in the periphery, that's not a really helpful way of determining whether a vessel is an artery or a vein. As you get more proficient and spend time looking at literally thousands of arms and legs, you get pretty good at just being able to look at certain anatomical positions and fairly quickly identify which is most likely to be your artery and your vein. But every single time, we need to do a full assessment and make sure that we identify which vessels are which, even if we're only looking, let's say, for a PIV, and I'm looking in an area where I know there's potential to also be an artery. And for most of our kids, that's most of the time because their arms and their legs just aren't very big. So most of the time, even when you're looking for a vein, a lot of times somewhere on your screen is also going to be an artery. So we need to make sure that we've identified where those are at if we're going for a vein, and so that we can stay away from that and make sure that we focus on just the vein. So in kids, when you're doing your basic assessment of an extremity, it's really important, number one, to make sure that your patient is very calm. So whether that means swaddling, sucrose pacifier, maybe in extreme cases with babies who are really non-tolerant, getting some pharmacological intervention. If kids are really touchy and just not able to handle any sort of extra stimulation. Um, Perhaps most of the time we bring a second person along just to provide comfort, because doing a really thorough assessment and making sure that we're making a good decision about which vessel to go in, that's going to really help set you up for success. And sometimes ultrasound use can feel kind of cumbersome on the front end because it is a lot more work setting up, doing an assessment. Maybe you don't find anything on the first extremity, so then you got to kind of start over and go look at another extremity. It kind of feels like a lot, or it's not as easy as it is to just walk up to a bedside and stick a little peripheral vein in the hand. But I promise the more times you can do it, the quicker you'll become and the more adept you'll become at making really good decisions and being able to really identify what would be the best choice for the patient, and being able to identify just the difference between your arteries and your veins much more quickly. So in general, once we put the probe on an extremity, what we're obviously looking for is big black round circles, right? Those are going to be our vessels. And the way that I like to really identify and confirm the difference between my artery and my vein is with pulsatility. Our arteries should be pulsatile. If you hold the probe gently on the skin, you're likely to not really see any pulsatility at all. Everything will just kind of look open and round. If you hold the probe nice and still and just apply steady pressure downward to collapse those vessels about 50% of the way, what you're going to find is veins are going to collapse much more easily because of the types of wall that a vein has than an artery. So a lot of times if I start to put downward pressure on an area where I see a couple of different vessels, my vein is going to collapse really, really quickly. My artery will start to close, but it probably likely won't collapse in quite the same manner that my vein does. And the other thing that I'm trying to do is if I can get those vessels collapsed down to about 50% of its normal diameter and hold nice and still for just a few seconds, you're going to see flickering and pulsatility in the wall of whatever vessels are arteries. And we all know that anatomically in the distal arms, we're looking for the radial artery, the ulnar artery. As we move up the arm, those come together to form our brachial artery, and then up into the very top of our arm, our axillary artery. What I can tell you is that additionally, in addition to those main arteries, kids can have collateral versions of all of that everywhere. So even if you're fairly certain you know where the arteries are supposed to be, it's really important to take your time and do a good assessment because especially in kids that have cardiac defects, abdominal wall defects, or CDHs, those kids have vasculature that does not follow the normal pattern. And they tend to have way more collateral circulation with their arterial circulation than they do with their venous circulation. So what we're looking for when we're doing that assessment is we want to identify any pulsatility anywhere on the screen. We want to stay away from those because we're really looking at doing peripheral veins first. And then what we're looking at, in addition to identifying which vessels could potentially be arteries, we're looking for veins to be nice and round under ultrasound. We're looking for them to collapse really easily. And then when we release that pressure, we're looking for them to really rebound and open back up to that nice round form very quickly. That tells us the vessel wall is healthy. It tells us the vessel itself is well perfused. Sometimes you can see things that look nice and black and round, and when you go to push down on them, they just don't collapse. They don't want to budge. They don't want to move. And so in that case, it's probably either not a vessel, maybe it's a nerve bundle, which can look very similar to a vessel, or that vessel has already maybe been recently used for something, and that wall is a little bit sclerotic and it's a little bit irritated, and it does not want to, it's not feeling very healthy at the moment. So that's something that we want to stay away from as well. So really trying to preserve the health of the vessels. And before we get into considerations for peripheral vascular access, just going back to that previous slide for a second, don't be afraid to do an assessment. I usually encourage people to do it at multiple points along the vessel because we not only want to see where it looks like at our entry point, we want to see what it looks like as we advance up and down the arm and check it at several different points. That'll usually give you a really good indication and help you feel comfortable about the vessel that you're going to go for. So now moving forward into considerations for peripheral vascular access, just some things to think about in terms of preferred sites. We really, at this facility for PIVs and for peripheral art lines, we stay below the antecubital fossa. That's kind of that sort of line of demarcation where we really try to differentiate between central vessels for PICs and then peripheral vessels for our PIVs. And in terms of the lower extremities, we try to stay kind of like below the midpoint for the knee, between the knee and the ankle. This approach really helps to protect our larger, deeper proximal vessels for potential PIC placement. Again, this is where our assessment comes into play because if there are just not good options for our peripheral vessels, this may be a patient that we may need to lean more towards considering a PIC line more quickly. Some things that you can do to help improve peripheral perfusion. Obviously, warmth is like the number one thing. So making sure your baby is normothermic. Adding, one of the things that we like to do is we will add heel warmers to arms and to legs and let them warm up for about 5 minutes, and then slowly take them off one at a time and kind of go back and look. We find that to be incredibly helpful in just helping to dilate those vessels a little bit more. Again, whenever you're doing your assessment, that needs to be completed without a tourniquet on so that we can really get a good assessment of what those vessels look like in their natural state and not to apply the tourniquet until right before we're getting ready to stick. The question that a lot of people ask is, can I use a larger, more central vessel for peripheral, for PIV placement? And the answer is, of course, yes, you can. I think you just need to be very cautious, particularly in those small neonatal population, about how many times we do that and what our goal is about trying to get using a peripheral IV into a larger, deeper central vessel. So times when we would do that, obviously during a code or any time of any type of like resuscitation where peripheral perfusion is just really, really diminished, that would be a time when we potentially would use more of a PICC vessel for a PIV to provide medications and fluid volume resuscitation, things like that. The other time we would potentially use them is if a patient just needs like a one-time dose of a medication or a one-time blood transfusion. This isn't going to be a long-term thing. They really just need to get a single dose or a single treatment of something, and then we're able to, move on in terms of their treatment. What we want to avoid is really utilizing multiple deep vessels for PIV attempts and then ultimately being unsuccessful. And now we're like, well, I guess we should put in a PICC line. Well, we've already really taken quite a few vessels and in attempts for peripheral placement, and now we're just going to make our central placement that much more challenging for us. I will tell you what I have learned is that if you're out in the community, if someone tells you, oh, I tried in this arm, or oh, I tried this vessel, or oh, somebody else already attempted this, but they attempted it without ultrasound guidance. Most of the time, I would say 95% of the time, even if the vessel is considered to be blown or not accessible because it's already been attempted, a lot of times I'm able to look at it with the ultrasound and see that even though there may be bruising or something under the skin at the surface, when I look with the ultrasound, the actual vessel itself still looks pretty healthy. And so going back to those original assessment features where we're going to look for round, healthy vessels that are well perfused, that collapse easily and rebound nicely, um, those vessels can be used again, even if they've quote unquote been attempted, or even if an extremity has been attempted. Don't let that deter you. Go back and start from square one and do your assessment. And I think you're going to find good options, even when maybe the original attempts were unsuccessful. This is just a quick slide looking at the peripheral venous anatomy. Typically for our PIVs, we're going to be looking at the greater saphenous vein and the anterior and posterior tibial veins in the lower extremity. And then in the upper extremity, a fan favorite is the cephalic vein that runs kind of right on the top ridge of the forearm. That's a great vessel because it is not near an artery. It is not near a nerve bundle. It tends to run very straight. It tends to not be very deep. So that is a huge fan favorite among the team for really quick peripheral access. Additionally, we can also use, the basilic vein over on the more medial side of the arm, and then some of those like median antecubital veins that are running sort of through the middle of the forearm. Those are always an option as well. So going along with the assessment piece that we kind of talked about at the beginning, really making sure that we take our time to put our patient into a good position to be able to both do our evaluation and then ultimately place our catheter. So we really encourage people to use swaddling techniques, position the infant with the limb that you want to assess exposed, but utilize swaddling, sucrose pacifiers, or pharmacological interventions as needed or prescribed to help keep the infant really, really calm. You might have seen we always elevate the limb that we are going to use onto a rolled blanket. You can see in this picture, this is actually a PICC line placement that's about to happen, but the setup is basically the same for a PIV. We'd just be starting a little bit lower on the leg rather than higher. But we are going to utilize that blanket roll because you can see how the transport nurse is holding the foot down so that the whoever is using the ultrasound to place the catheter, they have a really nice flat plane of the back of that leg in which to work. Most of these vessels are quite shallow. Like I said, they're within that first centimeter underneath the surface of the skin. And so while we're going to have a little bit of an angle in our needle when we initially introduce the needle into the skin in order to get to the level of the vessel, once we start to get down to the level of the vessel, we're going to need to drop our hand angle and flatten out that needle and then continue to advance it into the vessel. So holding on top of or alongside of the person who's attempting to place the catheter, if your hands are up there on the same plane, it gets to be really, really challenging, and they're probably going to have a lot of difficulty getting the correct angle in order to advance the catheter. So we've sort of developed this technique of using a blanket roll. This can be done upper extremity, lower extremity, whatever you want. And so you sort of gently extend the extremity, and then whoever is holding drops their hand below the level of the extremity so that you're able to have a nice flat plane with which to do your evaluation. Again, just as a reminder, we're always going to evaluate without a tourniquet. We want to be sure that we're differentiating between our arteries and our veins, and that really needs to be done without a tourniquet because you can occlude arterial flow with your tourniquet and make it even more challenging to differentiate what is an artery and what is a vein. We're going to use that ultrasound to examine the entire distal portion of the limb, whether that be an arm or a leg. We can look 360 degrees around that limb, find the vessel that we feel most comfortable with. Then we're going to evaluate the specific features of the vessel itself, namely their compressibility. So the vein should easily collapse under pro pressure and then refill quickly. We want to look for a nice thick wall. Remember at the beginning, we were kind of talking about the differentiation between the nice black inside of the vessel where we should have really good blood flow, and then the white of the soft tissue. And what we want to see is a really clear delineation between those two. That tells us the wall of the vessel is pretty thick and pretty healthy. Sometimes in kids whose vessels are more poorly developed, or in kids who have really poor peripheral perfusion, the difference between the wall and the interior of the vessel can appear much more gray and much more grainy. Um, and so what we really want to try to do is steer clear of things that look sort of fuzzy and not as healthy looking, and go find ourselves a vessel that looks a little bit better perfused. That's going to help make us a lot more successful. Um, Remember, again, we're looking for that hyperechoic border and a really dark, that anechoic center. And that's going to really help us identify the bright white of our needle tip and then allow us to stay within the vessel during the entire placement procedure. And then finally, just some tips for success that we have sort of put together over the years. Um, We cannot stress enough the importance of really doing a comprehensive assessment. And again, I know at the beginning this is going to feel cumbersome. It's going to feel like a lot. Sometimes you might spend 15 or 20 minutes just trying to figure out where you want to start at. That will get faster and that will get better with time. But it's really important for the patients that we're making good decisions for them. And we talked about, swaddling and making sure that the patient is calm before we begin. And also in terms of just your alignment, we really want extremity, probe, and then monitor or ultrasound monitor to be really in a direct inline view. Particularly when you're first starting, when you're learning, this is really important. You might see sometimes more experienced people turning their head and doing all kinds of contortioning to get things done. That's a lot more challenging. And so we really want to try at the beginning to take away all of those barriers and to really make you just focus straight ahead, moving everything in a straight line, keeping things in plane. And hopefully that's going to help make it a lot easier as we're learning. We really want to get that gray line lined up directly on the vessel. We're going to hold nice and still when we make that initial poke, guiding that needle directly at the gray line. Once that tip of the needle is fully under the skin, our eyes are going to go back up to the monitor. And then the goal is to never look back down at your hands. The person who's helping you, who's holding for you, they can help guide you about how much catheter you have left, or if your wing is getting caught. Let them sort of be your peripheral eyes. The ultrasound screen is going to tell you everything that you need to know about what's happening with your needle and your vessel. And so that's where your focus needs to be. Every time you take your eyes off your probe hand or your needle hand, it's going to move, and it's just going to make it more challenging for you to find it and kind of get back to where you were. We always want to use, in that same vein, we always want to use the probe. If we get separated from our needle tip, we want to use our probe hand to go find the needle tip. We don't want to sort of blindly advance the needle or sort of try to find where the needle is or find the needle tip by kind of just readjusting and jabbing the needle in there. We want to hold our needle nice and still and move our probe around until we're able to locate it again. This is the hardest part for everyone, is that our hands need to work with each other, but they should never move at the same time. So again, it's that non-dominant hand really guiding the hand that's holding the needle. So it's that probe away, advance your needle technique. And so really working on small fine motor movements with that left hand is going to help you to be successful. A lot of times when you're first learning, an experienced person will kind of put their hand on top of yours. We always want you holding the probe because we want you to feel what those movements feel like. But it helps us sort of give you better guidance as to where we're at on the arm, and just kind of help you stabilize yourself until you're able to sort of understand what I'm seeing and coordinate that with what my hands are doing. And then finally, always making sure that we're putting as much of the cannula as we possibly can into the vessel before we take that needle out. Again, that's going to give our patients the best chance for a successful IV, and then it's going to build those skills that we're going to need when we start to go to harder vessels. So again, I hope you enjoyed this presentation. I know it was a lot of information. This is just meant to be sort of a general overview. And thanks for listening.